Good evening, everyone. We welcome you to the webinar presented on the topic Voices from India by Women and Health Together for the Future, and the digital partner being ClearNet. I have a video to play, and then we can start the session. Now I would like to introduce Dr. Surekha Tayade. She is Vice Chair, Global Women's Health Task Force Network USA. She is a Professor, Unit Head, INMC, Savangi Varda, teacher, trainer, guide, mentor since 20 years. She is also the founding member, Vice Chairwoman, and Health Together for the Future, South Africa. Ma'am, over to you.
Thank you very much. And I take this honor and privilege to welcome all the faculty and the participants to this membership and program committee WHTF webinar, that is Women and Health Together for the Future webinar on Breaking the Silence, Voices from India. The theme for today's webinar is Domestic Violence and Gender Inequalities. The presentation will be from this webinar has been convened by Professor Vidyadhar Bangal, who is the professor and head of Department of Obstetrics and Gynecology at Rural Medical College, Loni, Ahmednagar, which is from India. And he'll be presenting along with his team 2 real-life stories, and then that will be followed by a discussion on the issue of domestic violence and gender inequalities by panelists from various countries like South Africa, Egypt, India, and Bangladesh. So this is the topic of today, and we welcome everybody for this discussion on this very pertinent and very important topic. At the outset, I would like to introduce Dr. Judy Lewis, who is the chair of Women in Health Together for Future. She is not able to attend today's webinar because of some family problem. Thus, we are having as a host Dr. Godwin Aja, who is the treasurer of Women and Health Together for Future, is professor and chairperson at the Department of Public Health Graduate School. Let me. So at Philippines, he served as temporary advisor, WHO International Dialogue on Evidence Action for Improving Health in Developing Countries, and WHO Department of Reproductive Health and Research. He was a member of the Cochrane Collaboration Steering Group, Fellow of GETS. Currently, he is the Africa representative on the Executive Board of the Network Towards Unity for Health. And presently, he is the treasurer of Women and Health Together for Future. I now invite Dr. Godwin Aja to address our participants. Welcome them.
Thank you, Dr. Sureka. On behalf of the chair of WHTF, Professor Judy Lewis, I welcome you to this epoch-making event, a webinar on the topic, Breaking the Silence. This does not suggest that we have been silent. It rather means that we want more voices to join us in advancing the cause of women's health globally. So today, we are delighted that you could join us on the theme, domestic violence and gender equality. And we have assembled a cream of highly experienced scholars and practitioners to address this theme. And we hope that the lessons that you will learn from this webinar will help benefit the work that you do. So we, on behalf of Professor Judy Lewis, invite you to sit, relax, and contribute to the discussion. Thank you.
Thank you, Dr. Godwin. And we have eminent speakers for today. And first of all, I would like to introduce you our chairperson, who is Professor Shakuntala Chabra. She is the professor. Am I able to, are my slides seen?
No, Sureka, it's Judy's slide, so you have to change it. You can just see Judy here.
I'm not able to go to the...
Yeah, now it's fine.
Okay. So Dr. Shakuntala Chabra is the director professor at Obstetrics and Gynecology, Mahatma Gandhi Institute of Medical Sciences, Sevagram. She is the officer on special duty at Utawali Hospital, Melghat, which is a hilly and forestry area, and she has been serving the rural women there with a unique program. Mahmuda, can you yourself?
I think requesting everybody to mute, and I think host can mute everybody. So please mute everybody. Only the speaker can speak. Yeah.
Ma'am, will I mute, ma'am?
Mahmuda.
Yeah, please mute.
Can you? Okay, shall I go ahead?
Ma'am, we have muted everyone. When required, the speakers can unmute themselves.
Okay. So I would like to introduce Professor Shakuntala Chabra, who is director professor. So still, Mahmuda is not muted.
It's not muted. She's not muted.
Now she has been muted. Okay. Thank you so much, Shalini. And just would like to introduce Madam, though she does not require introduction because she is so well known worldwide, internationally. She has been doing a great job as officer on special duty at Utawali Hospital, Melghat, where she has been serving rural women with her esteemed services there. She has been the member of Working Group on Women and Children and Adolescents, World Federation of Public Health Association, World Rural Health Council. She is the founding member of WHTF, Women's Health Task Force and Elderly Task Force. Also, she is a member. She is a governing council member at ICOMAR, Government of India, New Delhi. And we are very much privileged, ma'am, to welcome you and on this platform as the chairperson of today's event. We also would like to welcome and introduce today's chief speaker, who is Dr. B.B. Bangal. He is the board of directors at the Women in Health Together for Future. He is the professor and head of Department of Obstetrics and Gynecology at RMC Loni, Ahmednagar, India. And also he has been the member of governing body of the Nationwide Quality of Care Network. He has a teaching experience of 31 years and he has various research publications to his credit. Welcome, sir, to this great event, and sir is also convener of this event. I would like to introduce Dr. Shweta Kadam, who is the postgraduate student at Rural Medical College, Loni, has done her undergraduation from Pune. Then we have Shweta Devani. She has done her undergraduation from Kashibai Navle Medical College, Pune, and she is also a postgraduate student from Rural Medical College, Loni. We have four panelists. Professor Hester Julie is the Executive Director of Women and Health Together for Future, and she is the professor in the School of Nursing in South Africa, and she has developed and taught gender-based violence at undergraduate and postgraduate modules. Welcome, Professor Hester Julie. Then we also welcome Dr. Amani Rafat, who is the mini grant chair of Women and Health Together for Future. She is the professor emeritus of community medicine at Suez Canal University, Egypt, and she is a Fulbright alumna. So welcome, Professor Amani. We also would like to welcome Ms. Kamayani Bali Mahabal, who is a creative, innovative activist who works for gender, health, and human rights. She dons different hats at different times, which include clinical psychologist, journalist, lawyer, human rights, and women's health activists. So we welcome Ms. Kamayani on this platform, and we would also like to welcome our fourth panelist, who is Mrs. Mahmuda Rahman Khan, who is gender specialist and general secretary of Shishu Anjana, which is a women and child development center in Bangladesh. She is head of the Women Research and Training Center, which is a sister concern of Shishu Anjana, and she works as a gender advisor in USAID and Bangladesh. So we welcome all the panelists here, and I would now take the opportunity to invite our first speaker, Shweta Kadam, to present the first case story.
Good evening, everyone.
Yes, just let me look at the presentation. Okay.
Shweta, be loud.
Just give me a minute because I would like to. Yes, I do have the case study here. This is the case study 2. Udit, can you share the case study 1, please? Udit, are you there?
Yes, ma'am. Just a minute. I'm sharing it.
Yeah, I'm able to see it now. Just a minute. Okay, so please go ahead, Shweta.
Good evening, everyone. I am Dr. Shweta Kadam from India. I am a postgraduate student and a member of WHTF. I'm happy to be with you all, and I'm presenting the first case study of today's webinar. Real life story of one woman who presented to us recently. A 30-year-old woman came to the gynecological OPD for consultation regarding tubal ligation operation. She was a resident of nearby village. She was fifth para, living 4 issues, all daughters with previous 3 cesarean sections done in a private hospital, homemaker belonging to a lower socioeconomic class, studied up to 4th class. On further interrogation, she revealed that her husband is a drug addict, capitation and alcoholic, and tortures and humiliates her for having daughters. Husband used to abuse and beat her whenever she asked for his to undergo permanent sterilization. She was worried about the risk of further pregnancies, already having undergone 3 cesarean sections, and so wanted family planning operation. Husband wanted her to take more chances to deliver a male child. He used to demand sex without any contraception. This led to stress disorder in her. Excellent.
Hello, can't hear.
Women,
Hello,
women
Shweta.
was accompanied.
Can't
You can
hear.
hear. We can hear her, madam.
Woman was accompanied by her mother as she went to her maternal home to seek help from the relatives. She was admitted in the hospital and husband was requested to come to the hospital for the need of signature as his consent. He was counseled regarding the risk of further pregnancies,
Maybe
offered,
connectivity
and an
issue.
option of male sterilization. He refused for that, but gave permission for tubal ligation. She was operated here. Laparoscopic bilateral tubal ligation was performed. Husband was counseled and referred to the de-addiction center with the social worker. Woman came for follow-up after 1 month with her mother. She was satisfied and happy with the help and support provided by the hospital.
Thank you, Shweta. And this is the video of the woman who is being interrogated, investigated, and evaluated by the postgraduates of the department, and she's sharing her story. We have English titles on the video, so kindly listen to the story of this woman.
तुला किती मुली बाळ आहे? 4. लग्नाला किती वर्ष झाली?
Shrika, I think when the video is in presentation, sometime it does not work. So if you can just play the video separately.
It is. Can you hear the video now?
दुसरी नंबरची तिसरी मुलगीच
Yes,
आणि
ma'am.
सीजर कोणतं झालं तुझं?
Hello.
सीजर पहिले ना 2 नॉर्मल होते मुलगी मुलगा मुलगी जिवंत आहे मुलगा वारला. अच्छा आणि आता तिच्या पाठचे 3 सीजर झाले. 3 सीजर झाले म्हणजे शेवटची मुलगी किती वर्षाची आहे तुझी? 1 वर्षाची. 1 वर्षाची. मग आता तुला काय म्हणजे तू कशासाठी आली होती हॉस्पिटलमध्ये? ऑपरेशन. कोणतं ऑपरेशन? कुठं नियोजनचं ऑपरेशन साठी ना? का करायचं तुम्ही नियोजनचं ऑपरेशन? सीजर झालं ना.
म्हणजे तुझ्या नवऱ्याचं वगैरे संबंध घेतला होता का असं संमती का बरं
ते दारू पेत होते ना, मग तेव्हा ते नाही म्हणत होते. मग नंतर आईने इकडं आणलं श्रीरामपूरला. मग आईने ऍडमिट केलं. मग त्याच्यानंतर आले ते सगळं करायला.
ठीक आहे करून टाका.
This is another video.
प्रीती प्रदीप
तुला किती मुली बाळ आहेत?
4.
लग्नाला किती वर्ष झाली?
No.
काय नाही ते आईने गडबड केली ना, तर तेव्हा दिले त्यांनी.
आता 3 सीझर झाले ना?
3 सीजर झाले.
3 आहे 4? 3 सीझर. मुलगी किती आहे मुलगी?
तर चौथी मुलगी.
हे 4थी आहे. आता ऑपरेशन करायचे, मूलबंद ऑपरेशन. त्रास तुम्हाला काय काय त्रास झाला सांगा.
त्रास मला काही नाही झाला. 3 सीजर झाले. पहिले 2 नॉर्मल झाले, त्याच्यातला एक बाळ डेथ झाली. त्याच्यानंतर मग 3 सीजर झाले. डेथ झाली बाळाची, त्याच्यामुळे सीजर झाले.
सीझर मध्ये ऑपरेशन का बरं नाही केलं?
सीजर मध्ये ऑपरेशन ती नाजूक पिशवी होती ना, पातळ झाली होती, त्याच्यामुळे नाही केलं.
नाही केले का? नवरा परमिशन दिले का नाही त्यावेळेस? आता नाही, हिच्या आधी नाही दिले होते?
त्यावेळेस बोलले होते डॉक्टरला, पण मग आता डॉक्टर म्हणे आता नाही करणार ना, तर नंतर नाही म्हणले. जाऊ दे म्हणे, आता बरं झालंय ना, तर एखादं होऊ दे म्हणे.
आता ओके आहे ना?
माझी कंडिशन अशी होती, तर त्याच्यामुळे मी येऊन गेले दवाखान्यात. मला ऑपरेशन करायची गरज होती.
नवरा त्रास दिले का हिच्या आधी कधी?
त्रास तर असं चालूच राहतो.
काय काय त्रास दिला सांग. काहीच नाही करणार.
काय नाही, पेतो, भांडतो, मारहाण करतो.
मुलगा पाहिजे होते का?
ते संबंधासाठी त्याच्यामुळे
मुलगा पाहिजे होते.
भाई सारी बॉटल्स पहले धो के दो, तो मैं अंदर रखती हूँ. घस के दो सारी की सारी, बड़ी वाली भी और छोटी वाली, तो वो निकाल देती हूँ फिर अंदर से. पहले घस दो, सबसे पहले दो.
ते म्हणत होते का अजून मुलगा होऊ दे, मग करू म्हणे. तर मग माझी कंडिशन अशी होती, मुलगा तर मला मी मुलगा पाहायचा असतं तर मला मग तिन्ही पोरी गमावल्या असते, स्वतः जीवानी गेले असते. त्याच्यामुळे मी निर्णय घेतला ऑपरेशन करायचा. मग आईकडे आले, मग आईने त्यांना गडबड केली, त्या दवाखान्यात आले. सही आहे.
त्यांना सांगितले का आता ऑपरेशन करायला संमती आहे का?
हा,
संमती आहे.
So thank you very much, and now invite Bengal sir to just briefly summarize, and then comments from Professor Chabra about the case.
Good evening, everyone. We just heard a story of a woman who had 3 cesarean sections, 4 daughters, and now she doesn't want any further issue. But husband is insisting another pregnancy just to have a son. And the woman really doesn't want any further pregnancy. She knows, she's much smarter than him. She knows that any further pregnancy would be dangerous for her health, and she might, there may be some problem with her own health, and she might, whatever life she has, she may lose her life, or maybe her daughters will suffer because of her demise. So this is quite common issue that we face on day-to-day basis. These issues are coming more often to tertiary care hospital, because she would not have come to us, but since she had 3 cesarean sections, no one in the private sector or at other facility take chance to do any operation, including the tubal ligation operation or family planning operation. That's why she came to us, and we thought this is a one good case study, a lot of learning. We just heard her story, and the mental situation and the condition in which she has gone through. But ultimately, we could convince the husband. We actually gave him the choice of he undergoing a male sterilization operation. It would have been much easier than what ultimately she has undergone. But at least with our counseling, she agreed to undergo. He gave consent for her sterilization. She has undergone sterilization, and she went home on very next day of the operation, since it was done laparoscopically, and she came for follow-up. She was quite happy with whatever intervention we did, because she was really disturbed because of the risk of any further pregnancy. The issue what she has addressed or told us, that husband doesn't want to use any contraceptive because he wants pregnancy, and she knows that any further pregnancy would be really life-threatening to her, and that's why she came back to her mother's home. And now, ultimately, with our intervention and counseling, we feel that whatever appropriate was needed to be done in her case, we could do it. So this is in brief about the case.
Thank you, sir. And we invite comments from Professor Chabra.
Bengal, good that you brought this issue. This is, I can recollect from my internship, I can say, 71. Every now and then the senior sending us outside, you talk to the. So it's a common issue. What you have brought is that, especially when with you, it's not poor women, even rich. And I feel sorry, but I have to say, even educated rural women, sometimes they also, but husbands many times. So it is irrespective of the economic class, irrespective of education. It is something which is inside, I should say, that you should have a boy. And this has to come out. This has to go away. This has to go away. There is no other word. That till the time we have this feeling that boy will do the rituals, will take care of the parents and all those things when they go. When we are seeing in this world today, actually girls care more for their parents rather than boys. I'm sorry to say that, but this is happening very often here. At least this is what we see. So it is.
Yes.
I strongly believe that it has to come from inside women. So women have to feel they have to have their own esteem has to change. The society has to change. Then only we can't blame illiterate. We can't blame poverty. It is women and men. That's the difference. And till the time this changes, things will continue, and we have to keep on struggling. That's what I would like to say. Thank you.
Yes, ma'am. Thank you very much. And we have a second case, which Shweta Devani would be presenting, and I invite her to present this case.
I'm Dr. Shweta Devani from India. I'm a postgraduate student and a member of WHTF. I am going to be presenting the second case study for today's webinar, which is also based on a real life story who presented to us recently in our opening. She's a 30-year-old Nalipara homemaker who was educated up to 12th standard. She presented to our obstetric triage with 5 months of amenorrhea. She was requesting for a medical termination of pregnancy as she did not want to continue the same for personal reasons. She was married since 3 years and had one spontaneous abortion in first trimester 1 year back. Next slide, please. She was staying with her husband since the last 3 years. Her husband has a motorbike garage, which earned him a below average income. He was educated up to 10th class and belonged to low middle socioeconomic class. Couple stays with the widow mother-in-law in a small rented house. Next slide, ma'am. Her husband was an alcoholic addict and a smoker. There had been frequent quarrels between the couple on some extramarital relations of the husband, which he denied every time when she brought up the issue. He used to abuse her badly verbally and torture her physically, mainly by biting her badly all over her body and creating a fear in her mind of repetition of the same act if she brings up the same topic again and interfere with his personal life. Next slide, ma'am. She used to tolerate his abuse and used to keep quiet as she wanted to maintain her marital life. She became pregnant for the second time and wanted to have the child, but the incidents of abuse and torture continued and got repeated. She has been beaten and bitten again during her present pregnancy, like in the past one, which she could not tolerate. She had made up her mind to stay away from her husband forever and wanted to terminate this pregnancy. Next slide. These were the bruises which she presented to us.
These are the injury marks. And these are the bite marks also. So all over the body, she is having these injury marks. As we can see, some are old, healed ones, some are fresh ones, which she which the postgraduates could evaluate.
This woman was sent to obstetric triage from hospital emergency department, which is a casualty unit, for obstetric consultation and opinion. The casualty department had already reported her as an MLC medical legal case as she narrated her history of domestic violence. She narrated her story to the obstetrician and revealed that she is a victim of domestic violence and now wanted to terminate her pregnancy. On clinical examination, there were evidence of multiple fresh superficial injuries. There were abrasions, contusions, bite marks, and swollen body parts. There were old healed scars of past injuries, which was suggestive of chronic and long-standing nature of the same problem of domestic violence which she was suffering. History and examination revealed that her pregnancy duration was more than 20 weeks, which is beyond the legal permitted limit for MTP, and which was further confirmed by obstetric ultrasound. Next slide. Woman was offered immediate treatment for her fresh injuries and bruises. She was counseled regarding the prevailing legal regulations of medical termination of pregnancy and was also given psychological support by the attending doctors and the nurses. She was admitted overnight and was referred to the counselor, medical social worker, and then to the district hospital for further help and treatment.
Thank you, Shweta.
Thank you.
I have the recording of the lady where she has shared her story. For the purpose of anonymity, we have kept her in the shadow, and the audio only will be heard. However, we also have English subtitles.
कभी हुआ वैसे?
संडे के दिन।
संडे के दिन क्या हुआ?
हमारे दोनों का झगड़ा हुआ तो उन्होंने बहुत मारा है, इनको बताया मैंने जो काटा है तो
कशावरनं भांडण झालं?
हाँ, तो ऐसे बाहर उधर लड़की के साथ बात करते हैं तो मैं हमेशा उनको बोलती हूँ कि बात मत किया करो, बात मत किया। जब भी मैंने बोला है तब भी वो मारते थे। जब मैंने मेरी सास को भी बताया था कि ऐसा करते तो उस दिन मुझे इधर ही आने का था शिरडी, क्योंकि उनकी मम्मी पॉजिटिव हो गई थी ना, इसलिए। तो मैं सुबह बोली, मैंने देखा वो मैसेज चैटिंग, मैंने बोला फिर ऐसा मत किया करो, मैं भी जाने वाली हूँ। इधर ही 2 महीने थी, फरवरी मार्च में, अब 15 दिन हो गई थी। और पॉजिटिव की वजह से मुझे वापस इधर आने का था। तो उन्होंने बोला तू मेरे पर शक करती है, डाउट लेती है, ऐसा वैसा। तो मैंने डाउट नहीं लेती है, जो मैं खुद देखती हूँ, मेरे पास प्रूफ भी है अभी भी, तो इसलिए मैं बोल रही हूँ। तो बोले नहीं ऐसा, तो गालियाँ देने लग गए। तो मैंने बोला प्रूफ बताओ, बोले वो बोले फिर प्रूफ दे वाला। तो मैंने बोला आपका मोबाइल बताओ, मैं प्रूफ देती हूँ। तो जो मैंने उनके पास मोबाइल मांगा था, तो उसकी वजह से भी मारने लगे। तो मैं पकड़ने लगे तो काट लिया उन्होंने।
अच्छा, किधर किधर काटे आपको?
अभी ये साइड में 3 है।
So thank you, Shweta, for that presentation. This is a lady who is 5 months, carrying 5 months pregnancy and suffering domestic violence and abuse and being beaten by her husband with bruise marks, bite marks all over her body. So now I invite Professor Chabra to comment about the case and followed by Dr. Bangal's presentation. Madam, please unmute yourself.
It's a real tragedy, but unfortunately it's common in cities and villages. Cities also it is silence, villages also it is silence. The seriousness is also equal. I remember, I can't tell, one of our postgraduates, she was here in the department and her husband used to beat. And one day she was pregnant and one day she came and when I was examining, I saw something. I said, what is wrong? So she just looked at me. Then I took her to another room. I said, you can tell me what is it? Then she started crying. Imagine, she was becoming a gynecologist. And then she's pregnant. And then we discussed and finally they had decided to take divorce. But this girl wanted, because she never realized that he's such type of a person, she wanted this child. I still remember her Caesar and that baby is now a medical student. She took divorce from that man who used to beat his doctor wife. So this is very tragic, but it's very, and this boy, her son now is a doctor. That same child when she was pregnant and when I came to know that husband is a doctor. So it may be a laborer, it may be an educated man. I know of a IAS officer also, his wife was pregnant and she told me. I can share so many stories even in the hospital wards. So this is something which has to stop. And women, men, and society at large must try all possible ways to stop this sort of violence, which is partner beating wife. This is inhuman, I should say, which must not take place. Thank you.
Thank you, madam. And I now invite Dr. Bangal for his presentation about his views and the prevalence and the overall his views on the topic. I'll just be sharing the presentation, sir.
Yeah, please.
This, I think I started from this is the slide, sir.
Yeah. So, good evening again. At the outset, I thank Professor Judy, Professor Sureka, Professor Hester, Professor Godwin for giving me this opportunity to share our experiences from India. From its very inception, WHTF is working to improve the health and well-being of women all over the world. We are privileged to have very senior members who have spent their whole life for this human cause. We are happy to have Dr. Chabra as chairman for today's webinar. You just heard my two postgraduate students narrating stories of two women who presented to us with their individual problems. One woman presented with the reproductive health problem, another woman with the domestic violence. Reproductive health related problems are quite frequent and often, as we just discussed, as compared to the reported domestic violence problems. I don't say that they don't occur. They may be happening equally, but as far as the reporting is concerned, the domestic violence issues do not come to our level or maybe to gynecologists that often. So I thought that yes, this is the forum, and since it was the initial activity, and since WHTF thought that we are working mainly in the area of gender-based violence, I thought, why not start with these two case studies, which I had little evidences in support of the presentation. Next slide, please. So these issues identified in these two case studies, first case, reproductive health issues, and we saw that there was a son preference, and that's why the woman had to become pregnant again and again. Otherwise, she was quite happy with her daughters, which she expressed afterwards that I need to really stop producing children, because otherwise I will lose my life and my daughters will lose me. So that was resulting into high parity due to unregulated fertility, male dominance, which was quite seen clearly. There was a substance abuse to further complicate the matter. And of course, ultimately, the husband was taking help of violent activity in order to control his wife's psyche. Second case, domestic violence, very clear-cut case of domestic violence. And there was, again, male dominance was clearly seen. He was again addict. There was a marital disharmony and certain issues have been raised. Now, this particular woman wanted medical termination of pregnancy, but for everybody outside India, we have certain MTP Act, which does not allow us at present to have medical termination or to conduct MTP beyond 20 weeks of pregnancy. There are certain changes that have taken place, but still we have to really restrict ourselves to 20 weeks. And this particular issue of domestic violence has really resulted into psychological distress in this particular woman. So as we are discussing, basic issue is gender inequality, which is very much prevailing all over the world, but mainly in the developing countries, including India. Another issue which is quite common is the son preference. That is also common around the world, maybe with some differences here and there. And that also is resulting into a lot of problems. When it comes to India, there has been a tilted balance among the what we call it as a sex ratio. And with the advent of this ultrasound, which was actually a boon for the obstetrician and for the humanity, but it has been misused by some of our own fellow colleagues for determination of the sex of an unborn child, that resulted into losing the daughters before they are born. As Madam Chabra has rightly said, and as I also pointed out this fact, and it is quite clear, when we find that since last 50 years, 60 years, our literacy rate is rising, going up and up, but the sex ratio, and for very reason like son preference, is going down and down, or we are losing daughters. So that is what is happening. It is not only the education or the socioeconomic class that matters. It is the psyche, it is the culture, it is the something else which is responsible for this disparity. When we find that there is a son preference, this is usually the situation where, next please. This is usually a situation where there are multiple, now 4 daughters and a the son gets maybe youngest one, more loved one, but still the daughters get neglected as compared to the son in relation to the nutrition, to the immunization, schooling, education. Everything gets affected when there are daughters, and son gets a preference. This is one cartoon in this relation. He's asked, don't you have family planning? But the fellow says, of course, I know. I plan to have son, and that is how I am planning my family. Global gender gap by country, and this is very obviously seen that there is something called as a gender index, and the 2017 figures, which shows that green areas where there is a less gender gap, and the pink and the dark pink areas having severe gender gap. India having those light pink, but mainly The gender gaps are much more in the African countries. When a question was asked, have you experienced gender discrimination in the workplace? It is again said that women say that yes, 57% of the women say that yes, there is a gender discrimination, whereas only 10% of the men say that there is gender discrimination. So at workplace also there are problems. And this is quite obviously seen when we talk about the unpaid work done by the men and women. And in urban areas as well as rural areas, women work much more unpaid than the men. That also shows inequality. Gender inequality index, where there are 3 dimensions and how we measure them. The 3 areas which are taken into consideration are reproductive health, women empowerment, and labor market. 2 parameters, indicators are considered in the reproductive health, that is maternal mortality and adolescent fertility. Whereas in case of empowerment, how much of the women, how many women or the percentage of women are representing the country in the parliament, and how much is the educational attainment as far as the secondary level and above are concerned, and in labor market. So this is how gender inequality index is measured, and I have shown you all over there is a issue more in the in the African countries and South Asian countries as compared to European and American region. So can we go ahead? It is also said that women, UN women find that a woman's caste in India increases her exposure to mortality. That is another observation because of intersectoral discrimination, poor sanitation, and inadequate healthcare. These women get different castes. So there is again a problem of caste and creed, and that also causes discrimination between women and men. So this is often the picture: small child to this elderly woman doing the household chores. When I had been to Melghat, where Madam Chabra is spending her lifetime now. While returning from that Melghat, I have clicked that picture. I have not put here. All the small kids and the women were carrying such a huge the cut wood on their head that it was really so miserable. I have felt so bad that in that jungle area, these small kids, it was on their shoulder, it was on their back, and all of them were carrying that heavy wood. So that is also another issue. When it comes to partner violence, 1 in 3 women experience violence at the hands of the partner, and this is a global picture which shows that yes, maybe in the American region it is much less as compared to the rest of the world. And in India, gender inequality is quite common. 100% of the enrollment of girls in primary education, but only 75% are not enrolled in higher education. So dropout of the women in the previous slide, please. Dropout from the schools and colleges is very, very common in women than men. Child sex ratio is also disturbed, and literacy rate among women is also very low. So overall, all the education is affected, and maybe I will say at the end that education is the crux of the problem. If you want to really improve the situation, women education or girl child education is extremely important. Next slide, please. So these are another statistics: 1 in 5 women, and of course, it is also said when we talk of gender-based violence, it is also other way. Also, it is being reported. 1 in 7 men also report gender-based violence. About 1 in 5 women and 1 in 12 men have experienced contact sexual violence by an intimate partner. Next slide, please. And of course, with this COVID coming up, and we have also reported that the gender-based violence has increased during these COVID times. Next slide, please. Coming to domestic violence, it is again quite common all over the world. These are some of the figures of the African countries and India, Haiti, Egypt, everywhere. These are the percentage of women in the age group of 15 to 49 ever beaten by a spouse or partner. So it is quite common all over the world. Next slide, please. Similarly, it is also reported that out of 100 adult women who reside in the state of Alaska, so even in Alaska, 40 experience out of 100 intimate partner violence, 33 experience sexual violence, 50 experience intimate partner violence, sexual violence, or both. So it's a global problem. 1 in every 3 women around the world experience domestic violence. That is very clear. Unfortunately, 603 million women live where domestic violence is not considered a crime. That is another very important fact. And of course, a third of Indian women cover up the signs of domestic violence, and they just don't report and try to hide it. Forms of violence, as you all know, could be physical, sexual, and psychological. All over the world, this is another picture showing. So everywhere, around 15 to 20, or maybe in some countries, it is going out to 75% husband beating wives. UN survey. Next slide, please. Now, what are the responsible factors? This is what I have thought. Various factors are there, starting from the overall low status of the woman in the society, illiteracy adding to the problem, early marriages in developing countries, making these small girls vulnerable, dowry practices, I will be talking about this particular practice, and substance abuse in men, gender bias, son preference, strong culture and traditions, patriarchal society, and lack of political commitment to control all this nonsense. These are the factors. Early marriages, and even today, median age at first marriage is just hardly 18 years, whereas the first time the woman have the first pregnancy is 19 and 20 years. She's just a teenager or just crossed teenage, and she bears child, and she herself is not mature enough to really tolerate what goes on subsequently or control her life. Literacy rate in India in 2011. So there are still literacy is low, but of course, as we said earlier, literacy is not the only issue that that has influence on this gender-based violence or inequality or son preference issue. Dowry system is a global scenario. Again, it's a global scenario, whereas there are different types of only things differ, but the red patch, that is India and maybe Pakistan, Afghanistan, where this dowry system is quite common, and this orange patch is, of course, it is China and maybe whole of Africa. So there are certain different. In India, the woman, when she marries, she is expected to carry a lot of money, gold, and maybe some property which is in her name with her to her in-laws place. Whereas it is opposite in these other orange patches, where in Africa and in this China, I think, the things are exactly opposite, whereas there is no such system in the green patch. Next slide, please. Now, dowry-related harassment and crimes in India are quite common. As I said, there are a lot of suicidal deaths, there are burn deaths, there are harassment and cruelty due to dowry issue, and this is quite common. And it is said, next slide, please. It is said that dowry system is a curse on Indian society. So this is what is there. A woman dies in India over dowry every hour. That shows how common and how frequent it is and how serious the problem is. Next slide, please. Dowry is still prevalent in India. This is a World Bank statement. And although there are certain laws and regulations which I have just enumerated in the end, but still dowry persists. The nature is different of dowry, but we need to really work on stopping this dowry. It's everybody's contribution is needed to tackle this problem. India, we have a lot of women who have really been first and really created history all over the world, but we need really many women who can really take over the problems that women face. Even some agencies have taken, since a lot of these Indian societies believe in these gods and goddesses. Even they have tried to picturize by humiliating and torturing the women. You are really your own goddesses. You are bruising, and there is battered battering. So that one should not do, otherwise you are humiliating your own goddesses. There has to be a shift in culture. We have to have conversation about systems that are in place that allow sexual violence to flourish. Next slide, please. We need to unite to end this violence against women without leaving anyone behind. And there are, next slide, please. We have begun to raise daughters more like sons, but few have the courage to raise our sons more like our daughters. So that is another very important message for everyone. As I said, Government of India, looking at the various problems women which are facing, there are 10 laws which are being formulated and being implemented in India since last 40-50 years. And whatever problem woman faces, these laws, the government has tried to control all these problems by creating a law. So at least some fear factor is there in the mind of these men mainly, and so that the prevalence of these problems become less. But still there is no much reduction in the problems women are facing. People are maybe we have an expert in this area, and we will like to listen comments from Kamayani, who will really put a little more focus on this. As I said before, ultimately, if you want to really save these girls and improve the condition, change the scenario, what I feel, what is most important is educating our daughters, educating our girls, women, encouraging them to have postgraduate studies, and so that they become mature and know about these laws which have been framed in their favor, and that will really change the situation. Education is the crux of the problem. So let's unite, end violence against women. Thank you very much.
Thank you very much, sir, for this excellent presentation. Now we have a panel here, and I request the panelists to share their experiences. First of all, I would like to invite Professor Hester Julie to recount experiences from her geographic region, which is South Africa, and her work, and what issues prevail in your region with context to the two cases presented here being discussed. Professor Hester Julie, please.
Good afternoon, everybody, and thank you very much for this opportunity to share our South African experiences. I have decided that I would like to give an overview, a snapshot of the impact of the COVID-19 pandemic on gender-based violence in South Africa, because it has been devastating. And in order to give you a picture, I'm going to use the data from 3 authoritative voices. One is from an international organization. The second one is going to be a researcher from South African University. And the third one is from the Minister of Law and Order. You may not know, but in South Africa, we had very severe lockdown regulations, and it lasted for more than a year. And within the first weeks of the lockdown, the South African police reported 2,300 calls for help, calls related to gender-based violence. And this was only the South African police, which is usually not the first stop. So I'm going to now link that statement with the remarks by the director for the East and the Southern Africa from Amnesty International. And the director states clearly that in South Africa during this pandemic, the government has failed to provide the necessary structural and systemic support systems to continue and to support gender-based violence. And the reason that she's listing is that the protection services and the support organizations were not listed as essential services. That meant that they could not go out, neither could those who are being abused come to their services. So now I would like to link that specifically with the stats that was given by our Minister of Police. And he gave that, these are the most recent stats. The stats for 2020 and 21, and it was given now in May. And the report states that there was a decline in sexual offenses, but listen to the numbers. It is a staggering 9,518 people were raped between January and March of this year alone. And that, the minister said, was actually a decrease in the previous year. So compared to 2020, this 10,000 is less. And what they also have done is they've taken a sample of rape incidents. So they took a sample of 6,893 rape incidents, and of those, that sample 4,130 of these incidents, the rape took place either at the home of the victim or at the home of the alleged rapist. That is according to the police report. I think that actually contextualize and give us the grim picture of what has happened during lockdown. And I think the desperation of those who are being abused is captured by the researcher. And this researcher is a gender advisor to the social policy network at one of our leading universities. And she has done a study collecting data from every call center that supports gender-based violence. So her findings are that from the government gender-based violence and femicide command center, they've recorded 120,000 in the first week of lockdown. And in another one of the metropoles, they actually have reported in one day between 500 and 1,000 calls per day. So if this picture is not enough, I think we have heard in the last week what has happened to our country. We know there's an intersection between gender-based violence and socio-economic factors. That means that because of the food insecurity, because of the food insecurity, we can expect even an increase. But just to conclude, I would like to say, although this picture is very bleak, it just shows again how much goodness dwells within humanity. Because when the government could not provide, the normal grassroots and civic organizations came to the fore. They provided, they supported. And I think that gives us hope. In addition to that, our president has also allocated a few billions to support gender-based violence. So that is the context currently in South Africa. So thank you for the opportunity to give you a very brief and very broad overview of what the impact of the pandemic has been thus far in South Africa. Thank you, Madam Chair.
Thank you, Hester. That was a really staggering number which you have just shared with us. And I think the similar kind of situation is there in most countries. However, what you have reported is a very, very grim situation. In fact, I can say that COVID may not have taken so many lives, but what the second pandemic, the shadow pandemic of the violence against women, which women are experiencing in these lockdown situations, this is worse, I think. And it is really a very grim situation where everybody have to think and about how to, what kind of advocacy and how we could plan to really create awareness about this. Dr. Kamyani, Ms. Kamyani Bali Mahabal has actually expressed her opinion about the shadow pandemic in one of the webinars hosted by WHTF. Now I invite her to talk about the legal aspect of both the cases and how these two situations can be dealt with in context of Indian law and her experiences in dealing with these situations. Ms. Kamyani, please.
Thanks, Surekha. The laws we know are there. The laws are there in each and every country. Now, in these first two cases, if I see the first case where the son preference is there, we have a law of prenatal sex selection, PCPNDT Act is there. And also it was discussed for the abortion in one of the cases that, you know, the husband was asked and then husband gave consent. As per the law, the woman does not need anybody's consent. But sadly, because of the situation, even the medical professionals, they think there's going to be a backlash from the family, which has happened in some cases. But a woman has a right on her body and autonomy. In fact, a few years back, the government resolution, in fact, from Pune, a women's organization has passed that a woman can come anytime. Because what has happened, we had done a case study on abortion when I was in Sehat, where certain women in rural areas used to change their village to go to another village because they didn't want everybody to know about their pregnancy. They would go to another village where then they would seek the abortion services without their family knowing also. Because again, the issue of having a baby boy. So the laws is we have, but what is the aspect of implementation? And all these, issues of gender violence we have discussed, I feel the patriarchy is the biggest umbrella under which all these cases of whether it's education, literacy, again, education and all, as we have seen, son preference does not go right from the poor person to the richest person. Everybody wants a boy. So education, what type of education are we giving to our children? Are we talking about gender equity? Are we talking about gender equality in our education, or education is patriarchal itself? Because I had also actually reviewed certain, 10th, 12th class books, NCRT books, which were again giving stereotypical images and stories of women being in kitchen, man going out and working. And these stereotypes of think, if we are going to put in education, then where women will stand. And I have been listening to everybody saying that, it's high time the women should stand. Definitely women should stand. But where is the support system for women? And it's also the man who has to understand. So I think it's a high time to engage men into it, because men are the people who are the agents of patriarchy, specifically here, who need to change. So in both these cases, the MTP Act was also there and the PCPNDT Act was also there. And there is also, we have a Domestic Violence Act. But the second case where the bruises were there. But my question again for the survivor and the victim is, they will not come forward because they don't have a support system. How will she leave her house? Where will she go? What about her children? So that support system has to be created. And I would also say that we have actually, I have worked with Dilasa in Bombay, which is like a counseling center which has a support of legal as well as medical, all coming together. So I think the coordination between the medical, legal and the women organization, right? And even the government, the state government has to be accountable, because we have Women's Commission under the Human Rights Law. We have State Women Commission where anything happens, we can go to them, or we have Human Rights Commission, but they are not being used. So the question is, we need to use all the platforms we have together in coordination in order to give justice to these women who are coming, because these, I mean, as we have said, they have become medical legal cases, but many a times these two cases which you have represented actually are not in isolation. As Shakuntala ji also said, they are everywhere. And I think Nigat is there from Pakistan and Mahmouda is there from Bangladesh, and especially in South Asia, the whole issue of gender is very similar. Culturally, very, very similar we are. And that whole male dominance and the whole patriarchal is working in different forms in different countries. So I think the time has actually come where in the various departments. So when we are talking about health, we need to keep the social determinants of health together. So people working in education, in housing, people working in all areas, legal areas. So there has to be a multi-pronged strategy. And I think WHTF should take this forward, coming up with a multi-pronged strategy, which could be adapted in, each country. I mean, our member countries. I was just thinking aloud. I just got this idea in my mind that suppose if we can sort of simply have for especially health laws in a very simple form, if we can have small booklets or some form of awareness material to reach out to people. It is also that people are not aware about the laws which are there, right? And they are also afraid to go to court. So I feel destigmatization of the legal process of going to courts also needs to be there. Yeah. Thanks.
Thank you very much. And very pertinent points are being brought by Kamyani, that we all know the legal system exists, there are laws, but as rightly said, both the two cases probably won't go to the court. The lady won't be giving evidence also because there is no support system, as rightly pointed out. And maybe whatever punishment the law is giving is not, maybe 6 months or 1 year, and the husband will be back and she'll be facing a lot of backlash. So as rightly said, an intersectorial approach is very much needed. The Women's Commission, the political commitment, women's organizations such as Women and Health Together for the Future, creating awareness, providing support, all this is needed. So with that in mind, now I invite Dr. Amani Rafat to share her views about how we can go about finding solutions which could be intersectorial, which could be system-based, which could be community-based. So Professor Amani, your views, please.
Yeah. Thank you, Dr. Surekha. I'm happy to be here in spite all the talks and the stories are said. It is not new. All these stories are all over the world. And I can tell you similar stories in Egypt, as well as I heard it in South Africa and other countries. Unfortunately, male-dominated and gender-based violence is everywhere. And as we know, it is 1 in 3. And it needs, as Kamyani said, laws are there. We have laws. In Egypt, we have laws. Everywhere there are laws. However, law enforcement is another story. And community and cultural pressure is a different story. I know a lot. I'm teaching in a medical school. So I was trying, because the violence against women is not taught in the medical curriculum. So I tried to introduce it in the curriculum in the form of problem-based learning as a case scenario, as you did. Unfortunately, I had resistance from colleagues that this is not medical, this is not health related. Or why do you want to show men as savage? But this is reality. This is reality. And when we talk about gender-based violence, it is not only intimate, it is in work, it is in the streets, and it is now there are increased in Egypt in a very disgraceful sexual harassment, especially with the rise of unemployment among youth and not lack of education. They are supposed to be educated, but they are not educated well, superficially educated, because they can go to school and get degree, but they are not aware, they are not There is no the benefit of education to see the world and to respect others. They can read and write, but they cannot understand the others. So if I want to change the world to have system, to increase the educational depth, to have in education from the young children, that they deal together, they are equal. Boys and girls are equal. They have different roles in life, but they are equal. Nobody is. This starts from childhood, from parents, that they do not prefer the son than the daughter. In our country also, there is not some preference, but there is permission for the boy to do others that girl cannot do it, because she has to be polite. What about the boy? What shouldn't be polite? So that it is in rearing, practicing, in education. So it needs cultural and support. I agree that we need support systems. Recently, in the last 20 years, we started to have shelters and support programs for abused women in Egypt. We have a hotline now. We have a women organization. But before that, when you go to rural areas, when I was working in the surveying domestic violence, they consider it a family situation that we do not interfere. Neighbors wouldn't interfere. It is none of our business to interfere. What happens, it's everywhere, because even beating their children is considered disciplinary. So we need to change the people point of view and the system. There are changes all over the world, and now, as we say, breaking the silence. We are doing it in everywhere. So systematically, we need more support from law enforcement, because now we have recently also anti-harassment police for women police officers and men police officers to prevent the harassment in the streets. This is an advancement, but it cannot, because laws cannot always be enforced, and a person who harassed a woman or exposed her in cyber bullying and could go away from it, because the judge is in his favor, because the laws are not so strict to support that. So I believe that there is always a hope, that there is a change all over the world, and we are hopeful to end similar stories.
Yes, thank you, Amani. Thank you very much. As rightly said, laws are not enough, and we need to work at the community level, at the society level, so that the issue can be addressed rightly. The root cause is not is certainly in the community and in the society. Here we have a comment from Troy Mastico Ivan from Uganda. And the comment is, in Uganda, at least people who have gone to school are less involved in domestic violence against women. However, in rural areas, people who have less information about such talks, and thus the high cases of women abuse. The supremacy of men is being reduced by the law, though the awareness of the law and the implementation of the law is still low. Thanks for this event, and thanks for the presentation, ladies and gentlemen. This is the comment, and thank you to Mastico for appreciating this event. Now we also have a gender specialist from Bangladesh amongst us, and I request Mahmouda to kindly share her view and her experience suggesting more solutions to the issues. Mahmouda, please.
Thank you, Shureka. Can you hear me?
Yes, but we cannot see you. Yeah, now we can see you.
Because I have lost electricity at my home, so I'm just working through different mechanism. But you can hear me, right?
Yes, we can hear you. We can't see you, but
it's dark here. So thank you very much for inviting me as a panelist for this interesting and important topic. I'm very honored. As everybody said, the situation in Bangladesh is not a exceptional. It is very similar to India, you know. And in the recent survey, which is done by the government of Bangladesh in 2015, it shows that 82% of the ever married women are the victim of violence at least once in a year. And the girls who get married before their 54% girls get married before the age of 18. And you know, the COVID situation has actually worsened the situation, as you all know. And as a result, we also saw that the cost of violence in Bangladesh is 2% of GDP. So which is a huge cost. Though we have been having this webinar through this Women's Health Task Force, I strongly believe this gender-based violence is not a health issue. As Kamiani and other people said, it needs multi-sectoral intervention to prevent this situation. In Bangladesh, we have a number of good laws in terms of the dowry, in terms of prevention of gender-based violence, but the enforcement is very, very poor. And the reason behind that, as you know, that the commitment from the political parties, from the government, for everywhere, I find the commitment is very low. I think the law comes much later, but I felt that one, and as Dr. Bangal and other people also said, that the patriarchy and the masculinity is one of the major reasons for the gender-based violence. If you ask me, I felt that, you know, that we as a parents failed to raise our son. Totally failed. I mean, I take the responsibility because I felt that, you know, if we could actually raise our children equally treated in the household since birth and even from beginning of the conception, the things could have been completely different now. We actually raise these children through a very socially gender discriminatory process, which actually allow men to be violent at the later stage. And I feel that is very true. So that's why I think that it is very important to think about how we can actually take a stake in the whole full circle, so we can contribute a little bit to raise our children, look at the future, that we can raise boys to, nicely. As a development practitioner and a trainer, I feel the gender-based violence is not an isolated issue, and we should actually, when I provide training, GBV is actually a core component of all my gender-related training. I also work as a USAID as a gender advisor, as you know. Recently, what we have done in US government is very committed for prevention of gender-based violence. And we incorporated that in every sectoral program. I think that is also key, because if you actually design an intervention for prevention of gender-based violence in the South Asian context, you are actually making men more resistant. So what we have done, that we have incorporated GBV when we do the gender analysis and try to find out how GBV actually affecting, be it agriculture, be it environment, be it health, be it governance and democracy, so that we can tweak that issue in different ways when we provide training for the professional, when we training for the frontline worker, you know. And definitely in the health, we have the screening mechanism. We actually refer them to the one-stop crisis center from the government, you know, where they get all kinds of support. But the key thing, I think, that we have to understand, the GBV actually affects a human being. When it affects a human being, is her productivity, her mental health, her physical health, and its cost to the nation as the society. So that's why I think it's very critical that we have to take two steps. One is actually we have to incorporate that in every sector while we do any kind of intervention, and actually engage men in very positive way, encourage them to have the positive masculinity and help them to change in the gender roles within household. All the time we talk about gender equality and gender equity, that hasn't been translated how you change or bring the transformation within the household for changing the gender role. So I should actually, and the support system, as Kamani was saying, there are a few support systems, so we have to definitely have that. But that comes much later when the violence happens. But in the prevention side, I think we can do a lot more effectively as a development professional, as a actually trainer, as a parents, very much. Thank you so much for giving me the opportunity to stop here. Thank you so much.
Definitely, it was wonderful the way you have expressed the various kind of interventions. And as you rightly said, the laws come later. What we have to address is the patriarchy and the masculinity which is existing in the society, and the interventions you have suggested, like engaging the men in positive masculinity and creating crisis centers, and you have also talked about, trying to address the issue by how we raise our children starting from the conception itself, starting from those early years, that will really affect and that will cause the positive impact in this issue. Thank you, Mahmuda, for raising those issues. And now I invite our program committee member, Professor Nigat Huda, to summarize the overall learnings from the session. Nigat ji.
Thank you very much, Surekha. Can you hear me?
Yes, we can.
Okay. Thank you, Surekha, for doing such an excellent job. Thank you, Dr. Bengal and the rest of the panel. I'm really grateful to you for inviting me. But I think we have raised a very important issue and we need to continue working on this issue because this is not only to do with medical people, medical personnel as hello. Can you hear me?
Yes, yes, we can. Nigat ji, please go ahead.
We can. Okay, but as mentioned that we need a multi-group, multidisciplinary or multi-professional group who should come together maybe in our next webinar and we can discuss, further because, like I think many of our people are hooked to dramas and our story writers really have a great influence on them and we always show as women being, battered and, not being treated equally. And we also need to invite other social, maybe from the police or from the legal, so we have to have a multi discussion as to why this is happening. And Mahmuda has already raised very important that it's also to do with how you raise your children, but it also has to do with the textbook that we use and how those textbooks also can include in schools as well and teachers training as well. And then we can, by bit and pieces, we need to transform our society. So I feel we need to continue with this discussion and not leave it here because this is very, very important. These are very important issues. Okay, Surekha.
Thank you, Nigat ji. We have some questions in the chat box, which we would like to take this now. I open the forum for discussion from the attendees also. First of all, we invite Resti who wants to comment. So Resti, you can go ahead. If we can allow her, Shalini, can she be talking? If not, she can comment in the chat box. And there is a comment from Ephraim. Is it possible to eradicate GBV culturally? So Godwin or any of the experts, if we can address this.
Rekha, actually, if you just one example of female genital mutilation.
One of the devices has to be closed. Oh, there is a lot of echo.
We can't hear you.
Now you can hear me?
Yeah, if you have two devices, close one device, madam.
No, I have only one. Okay.
Okay, please go ahead.
What I wanted to say, it's just culture and law. Say, if you just simple example, if for genital mutilation, female genital mutilation, so many countries have raised, they have got now laws. In culturally also many women organizations are saying no. But some part of the society is so bent upon it that, so it is as somebody has brought that it is from, you take care of the child at home and take all sectors. It is health, it is police, it is education, it is media, it is social. So it has to be a comprehensive attempt from upbringing of a child, or rather than saying child, it may be a female child, it may be male and female child, both together. So the atmosphere in the family, the society, and bringing all together. It may not, if we say that we health providers can do, we are sadly wrong. As someone said, it's police it is media, it is other side, education, and everything where all parts of the sections of the society must unite to remove this nuisance, I should say.
Yes, ma'am. Thank you very much.
From the earth, from the globe,
Yes, ma'am.
from everywhere.
We have a comment from Hester, and she has commented that the central role that faith-based organizations play in addressing intersectorial factors related to GBV was illuminated during this pandemic. I agree with you, Hester, here that churches and other religious organizations do play a big role here. And thank you for bringing out that issue also. Do we have any more comments?
Yeah.
I can't see more comments. I wanted Resti to be upgraded to a panelist. Shalini, can it be done so that we can hear her views?
Amani's hand is up.
Yes. So with that, I think there are no more comments in the chat box. So we would like to hear from Godwin about and conclude the session for today.
Thank you so much, Dr. Sureka. I know we all would agree with me that it has been an exciting session. Thank you, dear presenters and the panelists. It's been quite enriching. Of course, indeed, gender inequality seems to drive domestic violence and all the other associated health outcomes on women. Yes, I agree that indeed we need a system approach in addressing all of these issues. You know, a system approach that will help to elicit political commitment and intersectoral coordination and collaboration. That is very, very key. Collaboration with faith-based organizations and the education sector and the law enforcement segment and all of that. So, and of course, the idea of ensuring that we engage the men in this discussion. It's also very, very critical. And it's important that I mention on behalf of the chair of WHTF that WHTF is already doing a lot in addressing some of these needs. Recently, we awarded 9 mini grants aimed at obtaining more information on these issues and also even carrying out some intervention programs. So WHTF is already on the move, and we plan to do more, especially as an offshoot from these discussions, to think of coming up with some advocacy interventions to deal with the issues that you have raised. So thank you so much for participating, and our membership is encouraged to come up with ideas on how we can deal with many of these issues and move WHTF to the forefront of addressing all of these issues. Again, thank you so much for participating. All our presenters, like I mentioned, these are experienced and scholars and the practitioners, and we have benefited a lot from their knowledge. Thank you so much, and all the best.
Thank you, Godwin. That was wonderful. And rightly, you have said that Women in Health Together for the Future has been working for women's health since so many years, since more than 25 years now. And this year, we have encouraged the mini grants, and the theme was 9 mini grants were awarded to the theme of violence against women in the context of the COVID-19 pandemic and the intervention-based the proposals were selected for these grants. 9 grants have been given of $1,000 each. And we are also going to conduct workshops so that we can work on more proposals and we can give grants to more workers who will be working in the community to address this issue. So we do encourage the participants to become members of Women and Health Together for Future so that we can collectively work on this issue. And basically we address this issue in the community and the society by doing small interventions in our local context. So the global issue of violence can be addressed with local solutions. That is what we want to communicate through our mini grant project, which is headed by Dr. Amani Rafat here. So thank you very much, and for this wonderful discussion from all these experts here. First of all, I would like to thank Professor Judy Lewis, who is the chair of WHTF, for encouraging this webinar and supporting, and Dr. Godwin Aja for hosting this webinar instead of Dr. Judy. And also I would like to convey my gratitude to the chairperson of today's event, Professor Shakuntala Chabra, by recounting her various experiences and sharing her views on solutions and interventions which we can have to address this issue. My thanks to Professor Vidyadhar Bangal for actually taking up this issue and identifying those two cases which are so much common in our country and which are similar to other countries also, so that this discussion and this dialogue is able to happen in our organization, and we are able to share our views. Thank you, Shweta Kadam. Thank you, Shweta Devani, for being with us and sharing your views. And of course, the panelists, the expert panelists, Professor Hester, Amani, and Mahmouda, and Kamayani for sharing your views. And thank you, Dr. Nikat, for being there with us. And she's also the program committee members, so we could organize this event. Let me not forget to thank our two coordinators, Dr. Udit Gupta and Dr. Chinmay Akre, who has coordinated this with our digital partner, Clarinet. So this platform has been provided to us by Clarinet. A gratitude expressed towards Clarinet too. With that,
thank you, ma'am. Thank you so much.
Yes.
Thank you.
So
Thank you,
Sureka
and everybody.
Thank you.
Thank you, everybody.
Wish you
Bye.
safety and health, and a very good evening.
Thank you.
Have
Thank
a
you.
great weekend.
Have a good day.
Thank you very much.
Thank you.
Bye-bye.
Thank you, Sureka. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye, everybody, and keep safe.
Thank you, ma'am.
Please end the meeting, Shalini.
Sure, ma'am. Thank you so
Same
much.
to
Ending
you.
the session here.
Thank you.